For us, it was a very important topic to assess the cognitive function of the patient before starting oral therapy. Because nowadays in oncology, we have more and more drug taken by oral way, and a lot of people who are and most of the people are elderly, more than 70, so we would like to evaluate it in a longitudinal study if the level of cognitive function could have an impact on the observance of this oral treatment. So that's why we designed it, and we included more than 100 patients. Most of them had metastatic disease because they have, most of them has metastatic disease. The median age was 70 years old, so it's quite old populations. And all of them so receive either targeted therapy or hormone therapy, but for a metastatic disease, not as an adjuvant treatment. And what we found that before starting the treatment, 50% of the patients had already some cognitive decline. So they were moderated decline, but they had cognitive decline. And in our group of patients, in fact, we didn't have a high rate of non-observance. It was just 10% of the patients did not observe the treatment correctly. But among these patients, we identify that the two major parameters that may influence on the cognitive observance was depression, and patients who had depression had a risk multiplied by 4, and as well cognitive dysfunction, and especially working memory. And it's particularly important because we know that working memory is one of a part of the memory that has declined with the age. And it's particularly important because this domain of memory is implicated in multitask. And for example, for the patient who have multiple pills to take, it could impact on the non-observance. And just to give you another detail that we find among our study, the median number of medication per patient was 6. So imagine, and you had our treatment, our cancer treatment, so it's very difficult for the patient to manage all the treatment they have, and we thought and we think it's a major point to improve for the future, and more particularly among oncogeriatric domain and for the people who. So we have to improve the assessment of cognitive function of our patient, and mainly among elderly patients, because it's a major issue if we want to be sure that patients take correctly their pills, so they are observant, but as well not mal-observant, and we want to be sure they take the pills in a good way and not to mixture of them, because we could be exposed at some toxicity if we don't take this precaution. Yes, it's a good question, because most of our treatment in oncology was IV routes. So it was not something we think about that, but with the development of targeted therapy, nowadays we have some treatment that taken at home by oral routes, and we have to be sure that patients take correctly the treatment. So that's why, in opposition than among our colleagues who follow patients with diabetes, they are very, they follow the patient since a long time for observance. It was not the case in oncology. And the second point is, in oncology, we never work on cognition. It's just an emerging, subject. So that's why it's the first study that assesses this particular point. But what I've told you is probably patients who are depressed maybe are more likely to are not observant. But we didn't find, for example, some correlation between patients who live alone or in couple, because we could think that the wife of a man could help to take the pill, but we didn't find that. But our really two major factors that could influence of observance was depression and cognitive dysfunction. Not in our study, yes. And probably, we didn't have a high proportion of patients with anxiety. We have a high proportion of patients who has some depression. So maybe that's why we just find among patients with depression and not with anxiety. So as our patients are mostly metastatic patients, usually the patient want to take their treatment because they want to have an active treatment. So we don't have the problem of the intentional non-observance in this group of patients. It is not the case when you are in an adjuvant setting, or the patient take their pills, for example, for breast cancer for 5 years, and sometimes they say, oh my God. In this case, we are with patients with metastatic, so the thing is quite different. No, it's really because they forgot to take them. I think it's a major point we have to progress, because imagine 7 pills, 8 pills. We don't know what we do because there is so many interactions. So maybe even for the efficacy of our drug, maybe we are not on the top of what we would like to do. So I think it's particularly important. And I insist among elderly patients, before starting an oral treatment in oncology, is just to check all the treatment they have, and to see if we can decrease this list, and to be sure that there is no interaction on that. Because, for example, there is some new generation of oral treatment. For example, PARP inhibitor we have today, it's 8 pills morning and evening. So imagine if you are already to take 6 pills. So it's a very important issue. I think it's a major issue, we have to work on it. Yes, my opinion is now we have to introduce in geriatric oncology clinic, because in France, but I think in other parts of the world, we have developed some specific clinic for elderly patients. And this type of clinic, or we try to find the frailty of this patient, we should include cognitive assessment better than we do today. And it could help for the decision. For example, if you have two possibility to treat, two alternative of treatment, one IV and one oral, if you have a patient with cognitive decline, maybe it's better to have it. Or if you choose to do an oral treatment, maybe you have to organize a nurse assistance at home or something like that to be sure the treatment is given correctly. Not so easy, because it's not patient who has major cognitive decline. So the first time you met them, you don't realize that's of cognitive. So that means you have to do some more subtle tests instead of tests we use in Alzheimer's disease. And so that's why we have to introduce that in our clinics for elderly patients.